before time. Even we won't take long this time. So the second case we are presenting from again oncology biopsy. This is actually the case. It's not a rare case. It is not a diagnostic challenge. But what we want to highlight in this case is a treatment method, which is a complex sort of intervention done for the hospital mechanisms. So we thought we'll share our experience. So I will request Dr. Navi to present the case, and Dr. Sadhvi will review the literature, and Dr. Sunil will summarize.
Good afternoon to respected seniors and colleagues. So I will be presenting a case and the Iot Technique. So, a 68-year gentleman with a comorbidity of diabetes, partner by occupation. Now, this smoker presented with a chief complaint of pigmented ulcer on left sole for the last 2 years. He underwent oxygenal biopsy outside, and then he was referred to IRCH and was registered in our clinic. On examination, his performance status was good. He had 3 into 2 centimeter pigmented ulcer over the left sole of foot with a 3 into 2 centimeter firm node. It was united palpable in the left inguinal region with 1 into 1 centimeter pigmented lesion on the anterior aspect of left leg. He did not have any lymph node in the popliteal region. The biopsy, which was done outside, reviewed here, it suggested malignant melanoma, and on IHC, it was positive for melanoma A and HMB45. The size of the tumor was 4 into 3 centimeter with a more than 4 mm Breslow thickness, and it was a margin positive resection. So on PET scan, the size of the tumor was 3 into 2.1 centimeter with a metabolically active left popliteal lymph node with conglomerated lymph node mass in the inguinal region. He did not have any nodes in the highlight region. So FNAC was done from the inguinal region. It suggested metastatic malignant melanoma. So here we can see in the picture diagram, in this image, this is a pigmented ulcer of the left sole with a pigmented nodule over the anterior aspect of left sole, which is suggested of intransient metastasis. So diagnosis was made. It was a malignant melanoma of left foot with intransient metastasis with inguinal lymph node metastasis. It was a stage 4 disease, T4B and 3C and 1A, because of the intransient metastasis. So with the background of this stage and since he had only metastasis limited to the limb without any systemic metastasis or solid organ metastasis, the available treatment for this patient were the surgery that includes the major amputation, including the disarticulation with lymph node dissection, and the medical management, including the systemic therapy and radiotherapy. But since it's a malignant melanoma, so malignant melanoma is not very much sensitive to chemotherapy or radiotherapy. So does we have any option to preserve the limb with good oncological outcomes? So the available option, to give the answer, the available option is isolated limb perfusion, which is a innovative complex limb saving surgical procedure. So we discussed these options with the patient. Simultaneously, we also discussed these options in our multidisciplinary tumor board. So finally, this patient was planned for surgery. He underwent left AIIMS lymph node dissection with hyperthermic isolated limb perfusion on 18th of December 2019. So duration of surgery was 5 hours with estimated blood loss of 500 ml. The 1 PRBC was transferred during the operation, and this serial ABC monitoring was done during the procedure. Now coming to the Iot Technique. So since it was a complex surgical procedure, it involved multiple departments, including the Department of Oncoanesthesia for perioperative management, and a CTVS surgeon for handling the vessels, and a nuclear medicine expert for checking the leakage of cytotoxic drug during the procedure in the systemic circulation with the help of radioisotope. So this is because since we were going for a major surgical procedure and it was done first time in our institute, we made our protocol. We made our departmental protocol along with a checklist. This checklist included pre-operative assessment, intraoperative assessment, post-operative assessment. In the pre-operative assessment, we checked for the patient-related factors, availability of the drugs and its doses, and the availability of the instruments such as Omnitrack, tourniquet, oxygenator, cannulas, and the availability of the blood products. And in the intraoperative setting, we check for the priming solution for the ILP machine, as well as the post-operative settings. We check for the regular check for the pulses and the oxygen saturation in the limb, and we kept the limb in elevated position, and we prescribe LMWH for 1 week. So this is the new dedicated ILP machine, which is recently procured in our department. This is the basic circuit which is being used in the ILP setup. It includes the oxygenator, the heater, heat exchanger, venous reservoir, and water reservoir, and the temperature probes, which were placed in the lower limb for monitoring the temperature during the procedure. Let's see the basic mechanism of the ILP. This is how the blood comes out from the vein, and it goes into the, it drains into the reservoir, which contains the oxygenator. Here the oxygen is added into the blood, and then the blood is passes through this heater exchanger. Once the temperature of the blood raise up to the 38 to 40 degrees Celsius, then we add the drugs in the circulation, and then it is enter into the limbs through the arterial catheter. So here we can see that this is the temperature monitor. We have to measure the temperature with the temperature probes in the whole limb throughout the procedure. Now coming to the surgical steps of ILP. So basically in this procedure, in this patient, the patient was operated under general anesthesia. The patient was placed in supine position, and the inguinal incision was given, and the ileoinguinal dissection was performed. After performing the ileoinguinal dissection, we isolated the vessels, both femoral artery and femoral vein. We dissected clearly and we looped them. After taking the control of the vessels, the hybridization was done. Then we did arteriotomy and veinotomy. Both catheters were introduced into the artery and vein. Then it was connected with the oxygenated extracorporeal perfusion circuit. And after that, we isolated the leak to prevent the leakage of the cytotoxic agent into the systemic circulations. Here we can see this is the artery. We have looped the artery. We have looped the femoral vein. And this is how we inserted the cannulas in the artery and vein. And we connected this cannulas with the catheters, and this catheter is connected with the oxygenated extracorporeal perfusion circuit. And this is how we isolate the limb from the systemic circulation by this tourniquet, and this tourniquet is tied with the omnitract retractor. And usually, we usually monitor the leakage of the drug with the help of radioisotope. We usually inject the radioisotope in the lower limb, in the regional limb, and we check the pressure uptake at the level of the cordium. If the count is more than 10%, if it increases more than 10%, it indicates the major leakage. So we have to prevent it. And this picture was taken from the other resources to just show how we check the pressure uptake in the precordial region. So temperature has to be maintained between 38 to 40 degrees Celsius. And after achieving that level of the temperature, we add the cytotoxic agent into the circulation, and we perfuse the limb with the hyperthermic chemotherapy with a rate of 500 to 700 ml per minute. The most commonly used chemotherapeutic agent is the melphalan. After performing this procedure, once the perfusion is complete for almost 60 minutes, we wash out the limb with the isotonic saline, and we close the arteriotomy and veinotomy. So this is the user-friendly monitor. We can see there. This is the temperature of the limb. This is showing the timings. This is showing the flow rate, and this is the pressure of the limb. So we can manage all these parameters from this monitor. And the perfusionist can also do these kind of settings through this monitor. And so this is the intraoperative picture. This is the closure of the artery and closure of the vein. So post-operative event was uneventful. The limb had normal pulse, color was normal, movement was normal, and patient was discharged at post-operative day 8. Patient was again readmitted with the limb cellulitis after 2 months of surgery. The color Doppler was normal. The patient was managed with antibiotic and fasciotomy, and by that we could preserve the limb. So patient was followed up after 6 months. He had partial response to the disease. There was no progression of melanoma. He is still alive, and by our dedicated and hard work, we could preserve the limb in such case. Now I would like to invite Dr. Sandeep for reviewing the literature.
Extremity cancers usually present with the primary bone tumors or primary soft tissue sarcomas, malignant melanoma or non-melanoma skin cancer. Surgery remains the main option for the treatment. Amputations and limb surgery are the options. Chemotherapy and radiation therapy have their role in specific situations. There are certain challenging scenarios to manage the extremity sarcomas or cancer. They usually present with the locally advanced stages and in recurrent stages. And in case of melanoma, intransient nodules, which are small skin nodules which are present away from the primary lesions, it is difficult to manage these kind of lesions by limb salvage surgery, and majority end up with the amputation. So various options are explored to avoid amputation. One of them is multimodality therapy, involving neoadjuvant chemotherapy, radiotherapy, and combination of both. But most of the soft tissue sarcomas and melanomas are relatively chemo and radio resistant, and the experience of the neoadjuvant chemotherapy is limited also, and there is no major impact on the limb salvage rates with neoadjuvant therapies. ILP and ILI are the innovative treatment modalities explored for extremity cancer. The concept of isolated limb perfusion is to deliver the high concentration of cytotoxic drugs into the extremity through regional perfusion. This is a type of surgically delivered chemotherapy to increase the local tissue concentration of the drugs, to increase tumor response, and to avoid systemic leakage and toxicity. Innovative surgically delivered chemotherapy includes intra-arterial chemotherapy like sarcomas and melanomas, hepatic primaries and secondaries, lung metastasis, and retinoblastoma. Isolated limb perfusion is used to treat melanoma and soft tissue sarcoma. History of ILP dates back to 1956, when an experimental studies to increase the dose of chemotherapy in the region of the tumor leading area were undertaken, and by the early 1957, experimental animal models for perfusion has been developed to determine the chemotherapy doses. And in June 1957, a 76-year-old man diagnosed with a melanoma with more than 80 satellite nodules came to an American hospital, and the patient refused amputation. So the first ILP was performed using melphalan, and there was a complete response with minimal toxicity in this patient, and the patient remained alive for 16 years. By seeing this excellent response, clinical trials were performed to initiate isolated limb perfusion. But for the last 6 decades, ILP has been evolving. It is not an established procedure as yet because of the complexity of the treatment and technical challenges. Because there is no dedicated ILP machines in the market, the lack of ideal drugs, the duration and the extent of hypothermia is not clear, and it is also not clear which patient group is to be offered isolated limb perfusion. It is practiced only in certain institutions, and the institutions which are performing are not practicing it widely because it involves multidisciplinary approach, and there is a special expertise is required to run the ILP machine. It requires a trained perfusionist, and it requires a complex and invasive surgical procedure also. There is a potential of high morbidity in the form of limb loss, and the catheters, cannulas, and the running cost of the machine are very high. And there is a lack of high quality evidence in favor of ILP also. By now, European and North American centers have standardized ILP for melanoma intravenous nodules and diseases confined to limb with multiple lesions, and where treatment is only amputation. In 1970s and 80s, phase 1 and phase 2 studies have been performed for ILP, and they showed promising results. And by 2000, protocol standardization has been done, but ILP is still underutilized. Indications of ILP includes treatment of intransient metastasis from melanoma, locally advanced soft tissue sarcoma for limb saving surgery, neoadjuvant ILP to reduce bulky tumors to allow successive conservative surgery and for palliative treatment of melanoma. Absolute contraindication includes obstruction of the target artery or subsequent major arteries, diabetes with peripheral vascular disease, and children with open epiphysis plates. Relative contraindication includes prior radiotherapy, large superficial tumors with dental involvement, brain metastasis, and wound or ulcer serious infections. These are the drugs used for ILP. Mainly melphalan and TNF alpha are used. Otherwise, in case of sarcoma, the doxorubicin and interferon has been also been tried. These are the drug treatment time protocols of upper limb and lower limb in case of melanoma and sarcoma. However, the use of TNF alpha with or without melphalan is controversial. This is an article published comparing the role of TNF alpha with or without melphalan, and the author has shown that at the end of 3 months, the complete response rate and overall response are similar in both arms, using only melphalan and melphalan with TNF alpha. These results can be reciprocated at the 6 month interval. ILP uses hyperthermia, and heat is supposed to cause direct cytotoxic effect on tumor. It causes pharmacokinetic dose intensification by local penetration of the drug, and it causes heat synergistic cytotoxic effect of chemotherapeutic agents also. Morbidity of ILP was very high initially, up to 50%, because of normal tissue damage or cytotoxic damage, and because of hyperthermia and because of pre-perfusion injuries. It can lead to even limb necrosis and limb loss. The morbidity of the ILP is usually measured by the Weiterding classification system. It contains five grades of toxicity, and grade 5 consists of necrosis requiring amputation. When we come to the soft tissue sarcoma, this is a meta-analysis published for the use of ILP in case of soft tissue sarcoma. The author studied around 19 studies, including around 1300 patients. Around 1100 patients underwent ILP and 150 patients under ILI. As we can see that the recent studies are having a larger number with an overall response rate of around 90% and a complete response rate around 20 to 47%. In this diagram, we can see that the limb salvage rate of ILP in case of soft tissue sarcoma using TNF alpha is around 71%, and without TNF alpha is around 75%. And complete response is to the tune of 27%, with a very minimal grade 4 or 5 toxicity. When we come to limb salvage rates, literature states that in case of melanoma, 85% limbs can be saved by using ILP, and 74 to 9% of the limbs can be saved by using ILP in case of soft tissue sarcoma. Here we can see in certain pictures. This is the sanguinary sarcoma, and after ILP it has shown changes of necrosis and decrease in the size. This is similarly we can see here. This is the soft tissue sarcoma. After ILP it is undergone decrease in size. This is the CT angiogram of a soft tissue sarcoma showing tumor blush, and after ILP that all tumor blush has gone. These are the multiple intransigent nodules of the melanoma, and this is the response of this intransigent nodule after ILP. Thank you. Now I will invite Dr.
Thanks, Dr. Sandeep. I'm here just to summarize what we saw. And just to recap again, figures will tell you that although this is a 60-year-old technology, but it doesn't look to be that new in the sense that majority of the centers are not used to this, at least in India, definitely not a couple of them. And just to recap how effective it is for melanoma and sarcoma, I'm not saying across the board all the centers, but yes, these are the figures which have been reported in literature. If you talk about overall response rate, up to 5 to 90% have responded, but more important is among these patients, almost 25 to 35%, they had a complete resolution of the tumor. Ultimately, the idea was how to salvage the limb with the disease control, and if you are able to see these figures quoted in the literature, 80 to 90%, this sounds quite impressive. But like every other procedure, and technology or technique, it has its own share of morbidity. And you have to understand that actually there are two components to this. One is the localized suppression of chemotherapy agents and addition of hyperthermia. But problem is that both of them have a very, very narrow therapeutic window. If you go towards hyperthermia more and more, you will end up with limb necrosis. If you push more and more amount of agent, and if you have leakage in the systemic circulation, then you are done. So these are some of the two of the most important toxicity or the reasons for toxicity which have occurred. But again, it all depends that how frequent or how used to that center is there, how experienced the team is there, and that still 10 to 20% of the patients will end up with some sort of morbidity. Again, recurrence after isolated limb perfusion, that will happen in 20 to 30%. This I am talking about combined local as well as systemic. These figures are fine, but more important is to look them in the context of certain facts which our country at least has, where majority of the tumor, a vast majority of them will be presenting in very, very advanced stages, and all of us are aware about the challenges which are involved in dealing with extremity cancers which are advanced or like encasing the neurovascular bundle, or for that matter, a vast area of skin or joint is involved, where it's traditionally the only answer so far has been amputation. And all of you will definitely, agree with me that offering amputation is one of the most painful things a surgeon can do. Not only this is physically debilitating for the patient, it's also, and rather more importantly, it's socially and psychologically. That's a big trauma one can. Even the fact that our rehabilitation system, at least in our country, is not up to that mark, both in terms of availability as well as affordability. So, if we think about the contribution of the traditional cancer treatments like surgery, chemotherapy, and radiation therapy, at least for these two indications which we are mentioning here, extremity melanoma and sarcoma, whatever the relative had to be there, more or less it has reached. Now, coming to the newer or the experimental modalities like immunotherapy or targeted therapy, they are still in the phase of evolution, so we cannot bank on that. So, if we need something to push this boundary of limb salvage, we need something really innovative. And ILP, although it looks pretty complex given all the pictures and the setup you saw, but that holds a very, very promising option just to push the boundaries of the limb salvage, where at least every limb salvage is a kind of bonus given this kind of treatment. I invite Dr. Dave to take the discussion further, and then we take up the question.
Thank you, Dr. Sunil. I think this is the case basically what we are highlighting here. We have been planning for bringing this modality. In India, it has not been done. We have been struggling with various machines. Some people are trying to use heart lung bypass machines, and collaborating with the cardiac surgeons is very difficult. So this machine was launched 5 years back in Europe. So with great difficulty we could procure it because there is only one manufacturer. The beauty of the machine is that we can do both high-tech as well as ILP, which is programmed for both the things. So the first case we did around 6 months back, we did another case. So the idea is, if you see Indian scenario right now, melanoma is not a very common cancer in India, unlike Australia or South America. For soft tissue sarcomas, we do see being a referral center. We have a database of around 1,000 soft tissue sarcomas right now. Our current limb salvage rates are around 70 to 80%. So at least that means 20 to 30% still we are ending up with applications. So is there any other new way to explore these? I think ILP is one of the options. I would like to thank our cardiothoracic department because we have to borrow the oxygenators from them, and some arterial carriers. Dr. Sri Chaudhary has actually helped us. And this machine comes with a disposable kit which will cost 1 lakh rupees. So single use. So we could procure 20 along with the machine. At least for next 20 cases we can do it. After that maybe we have to see how to generate more funds. So, but I think still it is work. I think AIIMS and these kind of setups are, I think, meant for pushing the boundaries and doing these kind of treatments.
So we are looking forward to, I think, starting some studies with Dr. D. N. Sharma and Dr. Samir Bakshi we were discussing. Maybe as a pilot project, maybe a limited number of patients who are suitable for these kind of modalities. So thank you. Any questions for Samir?
Partial response. So what are you planning for it now?
Actually, if you see the literature, the peak response happens between 3 to 9 months after IIT. It is not a dramatic sort of immediate response. Even melanomas we have seen the literature. So he's under close follow-up right now. And he has been seeing the medical oncology for, because now you see the last 3 years, there's a paradigm shift in the immunotherapy has come in a big way in melanoma. A lot of adjuvant trials, new adjuvant trials have shown very good results. I think that is another competing modality which will be, I think, already available in India. So that option is being explored along with this ILP in these patients. So one patient has received targeted immunotherapy, one melanoma along with ILP. And otherwise, peak response, they say you can watch up to 8 to 9 months. So that is when we can be 100% sure of whether the limb has been salvaged. Yes.
Just I want to highlight 2 points more like this, because we are doing IEP, isolated limb perfusion, but that is started in 1950, and because of the inherent mobility, like he already mentioned, 50% mobility because the catheter size is larger. Suppose say 12 to 14 pins catheter we use, and because the extra precision is there, limb is there, even the sensory loss, and during the thromboembolism chance is high, 20-30%. In 1990, the isolated infusion system came up, isolated limb infusion. So that is a particular technique, and even the catheter size is less. And people, along with this, the people are using also the alpha interferon, CTLA4, anti-CTLA4, and also the anti-PD1. So that is also good response time, because the thing is that here in isolated limb perfusion, the mobility is much more higher. And but the question is the response is very high. Overall response is 80 to 90%. Even the complete response is 40 to 50%. But in isolated infusion, the response rate is low. Like overall response is up to 70%, and that is the response. The complete response is only 35%. So further, people trying to use other things like alpha interferon, PD1, anti-PD1, like this way. But the question is, if you see this literature, overall response and the complete response is IEP is a better option. But nowadays the technique has been changed slightly, because we are using the open technique. But still, if you see the literature, people are using also the invasive line. So the particulars they are using the particular chapter and this. Gradually this is coming up. But there are challenges like this. I always think the challenge will be already started. Happy also like the same way. They are saying all the challenges to do this thing in our center. We think we should do this kind of things. Thank you very much.
Thank you, Dr. Ray. I think that's a good point. Actually, City Melanoma Center is the one who started isolated limb infusion. It's a simpler technique, but the experience is very limited. It can be used, but with the percutaneous technique, without a machine, only by gravity. But I think it is still the gold standard for regional perfusion in AIIMS is still as of today higher. Dr. Samir.
I have 2 questions and 2 comments. The questions is, what is cost for this procedure? You said 1 lakh is the cost of the catheters, and plus what? Because if it's in a certain range, I think it's I would say that we would expect that you do much more, and we have much more experience on this. And the second question is there any difference between doxorubicin and melphalan for sarcoma as the agent that you use? Because I would probably think that in sarcoma, doxorubicin being the most effective drug, one may expect a better response rate. So I want to know what is the information on that. After that, I'll give my 2 comments.
So the cost factors, the institute being highly subsidized, the machine is free for us. We are not charging anything for the machine. It costed us 70 lakhs the whole machine, but we are using for ILP and HIPAP. These kits, disposable kits, so it is offering at 1 lakh. Then the temperature probes which we use are supposed to be disposable, but we are reusing like any other Indian center. So they cost another 10,000 rupees. The oxygenator and the cannula setting was fully defined now for 20,000. 80,000. So that we are borrowing from CTBS, so they have a great contract. And the drug is not expensive, AIIMS and alcohol is not costing us much. So these three put together, I think for the patient it will cost 1.3, something around 1.3 lakhs. Yeah. So what we are doing, other model, if you see in IRC for the high-tech also, we procure these disposable cannulas, we keep around 20 to 25 sets as a bulk procurement. We use it for poor patients, free of cost. And those who can afford, those who have got the reimbursement, we are asking them to buy. So once a year we procure 10 or 15, keep them for a good patient who cannot afford, but still we can offer them. So, but otherwise it's coming to 1.3.
And between the
Drugs, yeah. You see, most of the drugs I think, if you see entire experience, melatonin has been the most widely used for melanoma and for sarcoma also they started with melatonin initially, and there are studies using radiomycin. But I think we need to make students.
I have two comments to make. So I will give three comments. I think the cost is pretty much visible. Even a very salaried surgery, one would do in orthopedics will cost that much or maybe even more. So the cost is not it's not too much. So I have two additional comments. One is I want to add that in melanoma, even if metastatic with immunotherapy, I would consider it today curative and not palliative. 50% of patients will get cured. I would not say this 10 years back, but today with melanoma metastasis, it's a curative intent. Regarding your comment on targeted, perfectly fine. You will prolong survival, but there is no end point up to when. Most of them will relapse at some time point. So that's my comment about melanoma. It's at a cost, but it's curative.
I was trying to ask the same question, sir, and maybe I can take it further that suppose you have a digital lesion after the IIT on the primary side. Yes. We go to surgery for the primary side.
So the strategies for using IIT or actually you see the literature, they are used in three strategies. One is unimodality, single IIT and don't do anything. The second strategy they have used as a neoadjuvant IIT for bulky tumors. So the big IIT downstage the disease and meant for clinical service. The third strategy is already being used as a palliative surgery, like metastatic, but with a little sort of a problem that are used in palliative. So it can be used as a neoadjuvant sort of an option. If you don't achieve a complete response, even if it is a partial, you can go ahead and drop it. That can be best.
Right. So do you, like in this case, do you do the retrosection first or the IIT?
Normally, you see, lymph nodes we remove here because there were bulky tumors, and sometimes regional perfusion may not cover lymph nodes in the eye. What we are targeting is the lymph, distal lymph to the lymph tourniquet. So if the lymph nodes are there, we dissect them first, then do the cannulation. If there are no lymph node metastasis, we don't do lymph node dissection. If it is only a primary with lymph node, you can straight away go for IL. No need to do lymph node dissection.
Last one, sir. Sir, why do you say that primary is a content for I'm not very comfortable with that. I didn't. Why primary is a content for
So that is, I think, basically issue effects of RDA, because not many people have done ILP following radical radiotherapy, because RDA is now being used widely for melanomas. So basically, there is a tissue tolerance and tissue toxicity. I think if it's already irradiated patient, if try to give us unilacet, hyperthermia, and have cytotoxic agents, I think it's more to do with the local tissue effects.
Also vascularity, means that you have more post-treatment fibrosis. It goes against the very principle of circulation, because more the circulation of the drug and the temperature you have, the more the technique will be effective. So once you have that fibrosis setting up, then the drug will get bypassed.
And I think outside of we are in a very exciting times as well as immunotherapy. Last 3 years, I think there are major breakthroughs in the field of melanoma. Now we have randomized controlled trials and adjuvant along with ILP. I think it's very for melanoma.
This is exciting as well, sir.
Does the ILP also affect the vasculature in the sense of thrombosis or the underlying fibrosis, which may affect the subsequent therapy compromise?
Long-term effects, yes, it has shown the lymph fibrosis will set in after sort of ILP. Long-term effects have been shown. Initially, when they were experimenting with unknown doses of hyperthermia and all, they ended up with tissue necrosis, severe fibrosis, joint fibrosis. The lymphs were not usable, so they stopped again. Then they again came back. I think it will definitely have a long-term impact on results.
Another issue is that we are not so far clear whether the hypoxia is helping us or it's against us. Now, newer studies are showing that actually it's going to be helpful. The only limitation is that there is only a time limit till that you can afford hypoxia in the limb, even if it's helping us. Now, taking the treatment duration to 60 to 90 minutes is not possible. That's the biggest problem with ILI. That unless you have a completely isolated circuit which is self-oxygenating, then you have a limit on how long you can perfuse the drug.
Limb ischemia.
Yes, that is the problem.
Regarding thrombosis, you were asking about that. Literature one in this study there around 187 patients with the multicentric trial. So they show the 8 to 10% is the thromboembolism evidence is there. And they are using that low molecular heparin for 4 weeks. But in our setup, sir, we already made a study this thing. In our patient particularly, we see this thing. Our rate of repeat is very less. Very less.
Okay, thank you.